A huge plus is when you are using it for hilar strictures and biliary malignancy. Sometimes you pass your guide wire, and then if you want to split the ducts into the right and the left system, and you're injecting contrast, and if we are not able to see the wire, this comes in extremely handy because because you're able to rotate your image. We get fantastic imaging. The protection from the lead shield is quite excellent. There's hardly any radiation, but now because they've got AI integrated within the unit, you hardly have any radiation at all. I doubt if I don't wear a lead shield, probably nothing will happen because the systems have got so good with good protection of the shield outside, with the clothing, with what we wear, and the AA integration. Your radiation is confined to a very small area. Setup. So the patient that you have today that I will show you is somebody who's referred for an ampullectomy. He had apparently an EUS and ERCP twice. He has not been cut. The ampullary mass, I am told, looks a little subepithelial. They are not sure whether it is just purely a villous adenoma and if there is something else going on. So they told me, please take a good look at EUS before you go ahead and do a resection of this procedure. I'm sure all of you do ampulectomies. It may not be a very fun procedure. And resection is not my forte. I do one colonoscopy a year. So I don't do any polypectomies. So I'm not the master of resection, although I do a lot of ERCPs. So what we'll do is we'll just do an EUS to start with. It'll be a quick EUS. And then after I do the EUS, we will go ahead and then we can use the fluoro setup and show you what it involves. So what I'm for you, I will once I go down, we will soon have to focus on EUS and endoscopy and EUS on the screen for our viewers. So I'm now in the stomach. Just going to have a very quick look at the pancreas. Let's show them EUS fan and EUS. So that is the pancreas, a very skinny pancreatic duct. There's nothing unusual going on here. There is the kidney, turn left. Once again, a normal pancreas with a very skinny pancreatic duct goes down. So there's nothing unusual about this body and tail of the pancreas. Is it inflating, Max? Is it O2 or CO2? Probably not, huh? So now I'm going to go into the second portion of the duodenum. Let us just have a look from the bulb. So that is the portal vein. That is bile duct. I don't see anything. It all looks okay. The head of the pancreas, no lymph nodes, nothing. So let's go and have a quick look at the second portion. Obviously, you can see there's a nice big ampullary mass here. Let's have a look, show them endoscopy view on EUS. So here is the ampullary lesion that they are talking about. It's a pretty bulky lesion, huh? Okay. So I'm going to suck air. That is the aorta. So I'm going to pull back on the scope. On EUS, all that I'm going to do is there is the ampullary mass. Even on EUS view, you can see it's a big, big mass here, right there. There's our mass. Important thing is to make sure it's not invading the muscularis layer. I slipped out, but that's okay. I'm going to ask Max to connect me the water pump here for a few seconds. Sometimes the ampullary masses and the ductal relationships are best studied when you put water in the duodenum because it opens up the mass and it makes floating of the lesion into the duct much easier. So there it is. I'm going to pull back gently. Let me magnify the screen a little bit and let me see, because I haven't seen both the pancreatic duct and the bile duct here. It's supposed to be a tubulovillous adenoma. Let me see. See here? You can see the ductal relationships very well here. Okay. So that might be both the ducts. See, I've got now the pancreatic duct of this is the bile duct and there is the pancreatic duct. I need to make sure that the ducts are not involved before I do anything. So I'm going to put water in. And then once you put water in, it gets much easier. Is it flowing? Are you sure? I don't think so. Okay, now it is. So there is bile duct, right? I'm going to get rid of the cursor. Bile duct there. Now water inflating. There it is. And what we are trying to do is to let the papilla float in the water. So there it is. So this is our ampullary mass. Here are the ducts. So I don't think there's any ductal involvement that I can see. So there is bile duct at the bottom, at the top, pancreatic duct going into the ampullary mold, letting go on the up down. Max, how much of water pressure do you have? 50. So I'm not seeing anything. See, you can see it pretty nicely here. You can go to 60. Yeah. See, I'm now submerged. It's pretty. Now you're okay, Max. So a lot of air. Now I'm submerged the papilla ampulla. Now you can see how beautiful it is. Right there. Can we record the EUS part of it, guys, please, if it's okay with you? So I'm now sucking out all the bubbles. So there it is. So there is ampullary mass, there is bile duct, and below that is pancreatic duct. And I think it's clearly there is no evidence of invasion that I can see of. See, it just stops right there. Right here, right? I don't see any tumoral growth into the duct, and it's not even a dilated duct. So I think it's good to go. So let's go ahead and take this out. I'm going to suck the water out and switch to ERCP. All right. Does anybody have any questions they can ask me? I mean, I can't hear. Since I don't have a two-way communication.
I think it's in the room, right?
So you can ask anything you want. It's just a few of us here. So feel free to ask any questions. Do you know what snare you want to use? You don't want to use. Okay.
Dr. B, thank you for your time. Appreciate it.
Good morning.
A lot of it is just, we kind of wanted to see room setup and imaging, and
okay,
it's kind of what we're looking for. So
which hospital are you from?
We're at Gunderson Lutheran, which is in La Crosse, Wisconsin.
Oh, La Crosse, Wisconsin. Ah, fantastic.
We're up there.
Are you near Marshfield Clinic?
So we're about 2.5 hours away from Marshfield. We're about 2 hours east of Rochester, Minnesota, right on the Mississippi River.
I got it.
Yeah, about 2 hours.
Are you guys are you putting up a new unit, or are you just modifying what you have?
We're still using a C-arm, so we're modifying a room. We're trying to upgrade. We've been expanding quite a bit, and
I think you'll like it.
Than what we got. Yeah.
You'll enjoy the system. So we'll drop the scope now. All right, let's go. So down into the second portion. So let's give probably Stephen the view that we need is the endoscopy for a while on a big screen, and then after that we will show EUS. Do you want to cannulate and show the PD and the CPD to start? I think we should, right? Or do you want to take it out? It won't really matter, I guess, right? Let's go take it out then. So usually we will always perform an ERCP to demo the pancreatic duct and the bile duct, because you want to know and make sure it's not a divisum. But for some reason, I feel fairly comfortable. In this particular case, we have a normal anatomy on EUS. I do not see any evidence of divisum. So we'll just go out and take it and then try to do the cannulation. One of the painful parts, after you take it out, you don't get the ducts. It becomes a problem, but that's okay. So here it is. Okay, semi-long. Max is my tech. He knows more about resections. We do about more than 1,100 resections here in this unit with my partners. So what size snare is this, Max? I think you need 3 men. Are you kidding me? Huh? No? It's a big polyp. You sure you're going to open this arm and get this in? Okay, open. Okay, go for it. Okay, maybe you're right, huh? Maxi? All right. Okay. Okay, so, okay. You got it? You think? Happy? I think so, right? All right, looks like it's a fair catch here. Are we recording this, Chuck, or no?
Yes.
Endoscopy. All right, if you don't, it's okay. I don't care. All right, are we tight? Yellow. Okay. So we've got it all squared off. Let's go and take this out. That's it. Huh? All right. Not grabbing it very well, but aye. Hold on, let's not fragment it if we can. Okay. It's not opening very well. Okay, grab it, whatever you have, and then I think I think, I'll take it out if you can, please. Huh? No? You don't think it's going to come? You don't have enough? Okay, go ham in the stomach. What do you want to know? You don't want to take this out now? Alright. We're going to just cannulate now and try to stem the PD. Let us see how it looks. It looks pretty good. Ah, wow. Okay, let's get pretty clean. We're just going to go straight for the pancreas if we can. So let's fluoro. And yeah, so that's our box. Center it. We're in a pretty good, decent position. Okay. Yeah. So I'm sure you have read it on the Red Journal. We wrote a pretty simple manuscript a couple of months back. So this is supposed to be a box is supposed to be the field of radiation. Everything else surrounding the box is a constant image that gets refreshed, I think, every 10 seconds. So radiation is very focused. So obviously we have nothing being exposed on us or for the patient outside the field of view. So let's get the wire out. Where? Here.
So who's running your fluoro right now?
We have a fluoro tech.
Okay.
We have a fluoro tech. I think that is better. Oh, pull me in. Careful, gentle. Fluoro. You can use a foot pedal. Sometimes when multiple rooms are available, that's what we do. We bring in a fluoro. We get the control for us, and then we use it ourselves. Not very often, but we do for simple procedures. Okay, go. I think we're maybe fluoro again. Gentle. Don't go soft tissue. Be careful. No, nothing. All right. See that? Soft tissue. Wire. So trying to find the PD. Okay. I don't like it, man. Wire. Okay. Pull me in. Gentle, huh? Very gentle. Fluoro. Try. Okay. It looks right direction, Max. Don't feel anything. Don't push anything. So that's probably bile duct on the top, obviously. Murphy's law. Fluoro. Go. Or not. Yeah, that's bile duct. Inject contrast so that we'll just get an image of it. Alright, so there's no rocket science to that part of it. We got the bile duct picture. So come out. We never stent the PD. I think it's probably here, right? Maybe it's down there. Okay, that's PD. Okay, try. Gentle, okay, don't push anything. Pull, 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 pull. You want to try a 5, 4, 3? Huh? All right. Not good. Huh? No, I don't like it. It should fly in. Okay. So try on the top wire. There. Try. Okay. Back to the bile duct. Huh? Yeah. Come back. So wire back. Let me see if it is somewhere down, Max. Try here. Pull. Huh? Try. Little too low for the pancreas. Yeah, urine. Pull me in. Okay. Fluoro. Let us see. Go. So if this doesn't work, generally we'll then try to go for the 543 with the overnight, the Nova Gold. It's pretty good for the pancreas. Not getting a good feel here. Not going anywhere. Nothing, huh? Okay, all right, come out. Wire again. Okay, right there. Try. Don't push your way, huh? Don't push your way. Try. What is that? Your wire is bending back. Can you pull back? See that? Okay, now again. No. All right. I don't know whether it is the tissue there that precludes the passage, but we're going to try the 543. It's a little sharp, so you get a good feel for where we are. We'll try it out. I'm also going to take a look at the minor, just to be sure that we are not dealing with a divisum here. There's a small minor there. Pretty quite prominent actually, like that. Huh. Okay. Looks promising, isn't it? I thought it's a pretty straight anatomy, but who knows? See that? All right.
Dr. V, out of curiosity, what settings did you use for your ampulectomy?
It's the same. What do we have? We've got endocut Q for a snare, 1A, effect 2, and then they've got 18 watts. It's a forced coag. All right. So this is a 543. So let us see if this will make it any easier. The minor looks prominent, although it did not look like a divisum at all. So this is 543, and then I'm just going to gently probe myself. The advantage of this is you'll get the duct. If it is there, it will just pass on very smooth inside. The disadvantage is it does cause tissue trauma because it's got a very sharp taper tip. It can cause tissue trauma. Okay, it doesn't go easy. No. So I'm going to try this right there. No. So I'm just trying to probe myself inside. No. 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 What do you think, Max? Huh? Let's try this. So I'm looking at. Can I have some glucagon? A little bit. 0.25. Thank you. Right there. Looks like see this. I think so I'm going to go back. No matter where I look, the central space is the one that keeps coming back to me. And try it, fluoro. Try and see if you get anything there. Yeah, tiny injection, very little. And then if you don't get it, no. See that? It's a soft tissue. So, all right, let's come back, suck some air. Time for us to look at plan B. Little unusual, but look at that minor. Want to try it? Try. Yeah. This is the time when you beat yourself and say, well, I should have done my pancreatogram before. All right. Let's, What do you say? Okay, let's go. Fluoro for a second. Trying to see if I'm in a good position for it. Yeah. Okay. We don't use secretin. Occasionally we do. But I think this is pretty, it's a pretty big minor that I think it will be okay not to use secretin. I think I'm there, Max. Can you try? Fluoro. Okay. You want to be on a long scope for the minor, and you can see the scope position is not the best for your divisum cannulation. So, trying it. Get a wire a little bit more. Yeah. Okay. Pull me in, Max. Sliding. You want to use the clover cut? What? You don't think it is a divisum, huh? It's a pretty prominent minor, man. So you're not getting a good long scope position. Fluoro again. See that? How the scope is? You're supposed to get a nice U-shaped scope for this. We'll try it once or twice, and if it doesn't go, generally then it is not a divisum. We'll have to go back to our to the major papilla. Okay, so try that. Yeah. Sliding away. Okay, pull, pull, pull. He's pulling me in. Okay. Slips away. Okay, I got it. Right there. Pull the wire back a little bit, Max. Just a tiny bit. I'm on the left of it, okay? Right there. Oh, sorry. Okay. Pretty positioned well. Fluoro, please. And then take me in. Can you see anything? If this doesn't go, then it's unlikely it's a divisum. We'll have to go back to the major papilla. Let me in. Okay. Okay, it's going somewhere. Hold on. Oh, keep me in. Keep me in. Keep me in. Keep me in. I'm in a horrible position, guys. Okay. I don't like this position. No. See, for this divisum, you have to be on a good long scope, stable position, and I'm not able to get a good position. Fluoro again. You want a U-shaped scope, and my scope is not good. Okay, let's try one last time before we go to the major. Wire out again. Ay, ay, ay. No. No. To the left of it. Yeah. Left of it, please. Yeah. Yeah, right there. So what happens is, you want to push the scope in. Okay. Advance, advance. Okay. Stay there. Locked. And then I'm slipping away because the scope is unstable. Okay. I'm going to lock my knob. Okay. Fluoro again. See how it goes. Go. Can you show me behind the scope? So one of the advantage here with the machine is you can see we can move it back and forth, and you can you're not hung up on a position. You can trace the wire right there. So that is not a good wire position for a divisum. It is supposed to take a turn the other way around, but we are just at the tip of it. After all, could be a normal anatomy. Pull me in, Max. Pull. So that's as good as I can get right there. Okay. Oh. Stay there. Anchor me. Pull me in. Thank you. Do you think we can get a okay. Fluoro. See where it will go. You're not going anywhere, huh? Okay. Luck. Okay. That's as good as it's going to go in. Unless you get your wire, I can do one cut over the wire. But right now, it's not going anywhere. Fluoro, please, again. Oops. I don't think this is a divisum. Yeah, agree. So by now, if it is a divisum, we should find our way inside. So definitely it is not. It is hiding somewhere here. Let us find it now. Okay. Maybe I need to be a little aggressive and push it in. Okay. Let me see. Definitely not there. That's bile duct. For sure. Come back. Down at the bottom. Not feeling it. See? Unless it's sometimes it's way up on the right side. Okay, where is that? Fluoro? That's bile duct again, huh? Yeah. But it's not freely going. Okay, fluoro. Try. Try the wire. If you inject me, I don't think we are going to get soft tissue. Try. No. See that? It's getting hung up. Right there. Try. Fluoro. No. No. Try that. Fluoro. Go. Okay. Try it. So Max is looping. Either we have a problem there. No. You think we'll be better with clover cut? See, that's again CBD. So if that is CBD, it should be on the top here, right? Sometimes it hides under here. Fluoro. Try. Go. Ah, damn it. So we're going to go back to the clever cut, not for anything else. It is just a sharp cannula tip here. And then what happens is every time you put the 543, we will cause tissue damage. So at least with a clever cut and the VisiGlide, the wire does the work, and then we don't have to worry about it. Okay, try get your wire. Huh? Huh? You're pushing me up? Okay, can I go? So, okay, try. Fluoro, gently. I don't know. No. So, shall we look at very low down at 4 o'clock maybe? Why, yeah. I've gone to all the usual places I should be going with this. Okay, try, pull. And I don't like the direction. It's going somewhere in the middle. Fluoro. Go. No. Okay. Hmm? Wire. Can we give indomethacin? Fluoro. We're going to start giving indomethacin now. Okay. No. Not a good feel. No. Okay, guys. You got any suggestions? These are just.
Those all look good to me. I don't.
I mean, the minor, it looked like it, but then it is definitely not a minor. Usually, if you get the wire, it'll go on. It'll creep in a divisum. So it's all looking pretty clean tissue here. I am getting an opening. Bile duct is on the top. And sometimes the pancreas will hide, the pancreatic opening will hide here on the right side. So we have tried that. Wire out, Maxi. Yeah, sometimes it hides way on the top. And then that didn't happen either. We keep slipping into the CBD. Pull me in. So fluoro again. Go, Max. See that? It goes into the bile. Yeah, that goes into the bile duct. So that is not the case. Where, man? So let us wire right there. Right. Hold on. Okay. So now we are going to all sorts of improbabilities there. Okay. Fluoro. Pull, 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 pull. Okay. Fluoro. Okay. Try. And then you can see that the wire just flips away, and no, Max, it's not going there. So that is that possibility is excluded. And there also comes a point of do no harm. After a while, I would rather just give indomethacin and take my chances of pancreatitis. And hard to believe there's nothing here. I've moved the folds. It can hide at 4 o'clock, right there. I haven't seen that. Wire. It is not there. See, this tissue doesn't look like anywhere there is PD there. Huh? Look at that. Possibly it's all from our injections. Okay, maybe that. Yeah, fluoro. Okay, go, pull, 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 pull. It just keeps coming to the same spot. Okay, go. No, no. You think a straight wire will change anything? I don't want to make any difference. Okay, pull me in. No, 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 no. Hmm? I don't know. So Max is telling me, will this be a common channel? Why not? We can put the sphincter on there, go down on the elevator completely, fluoro, and see if there is a possibility. Try. That's a straight shot. Okay. Falling out. Okay. Anchor me. So I'm going to go back in. Okay. No, bile duct. Okay. Let's come back. And then up, down, completely down, Max. You're not bowed at all. I'm going to pull back. So he's trying to see there's a common channel. Try, Max. Okay. Go. And my sphincteroderm is quite flat there. See, it's almost like, I don't think so. It's not going anywhere. Wire. Okay. Hold on. Okay. There. Okay, we're going in a different direction here. Pancreas. Okay, contrast. Inject. Whew. All right. Go there. Push it off. Can we get a check a 4 French 10 centimeter single pigtail pancreatic? Okay. Exchange. Good job. So there is PD. Yeah? It was right below the bile. See that? Right there at that opening. Maybe hardly almost a common channel. Yeah. Okay. Ready? Single pigtail, right? Yeah, no flange. So we don't put flanges for our pancreatic stents for obvious reasons. Stay there for about a couple of weeks and fall off. We also tend to admit these patients. He's coming from a place that is like 2.5 hours away from here. So we'll just watch him tonight and then discharge him in the morning. I don't know if you guys, ours is a referral practice, so we don't do follow-up on our patients. It's open access endoscopy. I haven't seen him in the, we don't do clinics. So we just review the records and schedule them for the procedure. And then afterwards, he will go and have his follow-up with his regular GI. It's a pretty big group. They're a group of about 70 gastroenterologists who are about 150 miles from here. And they've got like 6 or 7 advanced endoscopy trained people. So they are very good at what they do. And they will do the subsequent follow-up and everything on these patients. So we are pull. Excellent. Good. Yeah. All right. Fluoro. And yeah, we are pretty good there. Okay. Like that. And then I'm going to just let go and out. Thank you, sir. So we are done. So what do you want? You just use a snare to take it out. Follow. So I'm going to just extract this. What do you use? A rough nut or a snare? Open. You think you have it? Okay. Okay, it's a pretty big polyp actually. Oh, 2.5 centimeters. Okay.
Oh, wow.
All right, done.
Mm-hmm.